Hi, good afternoon, everybody. Today we're going to talk about fatty liver and NASH updates and some treatments. It's a very big topic to tackle in 20 minutes. So my main target is general gastroenterologists, primary care physicians, and people who see NASH and basically can approach it and deal with it. My target are not hepatologists. So the agenda here, we're going to talk about some definitions, some classifications, a little bit of epidemiology, the clinical course of NASH and fatty liver disease, how to diagnose and manage, and finally treatment. So to define really fatty liver disease, you got to have hepatic steatosis, either by imaging or histology. You have to have lack of secondary causes. You got to have lack of secondary causes that causes hepatic fat accumulation, such as alcohol use. Most of the patients with fatty liver do have comorbidities in the form of metabolic syndrome, which is obesity, diabetes, hypertension, high lipids. Here are some common causes that can cause hepatic steatosis. Those can be classified to macrovesicular and microvesicular steatosis, the commonest being alcohol intake, hepatitis C genotype 3, Wilson's disease. Medications, you've got both. Some medications can cause micro, some can cause macro. So the way we categorize fatty liver disease, we can categorize them into NAFL and NASH. NAFL, basically both of them need to have 5% of hepatic steatosis. In NAFL, there is no evidence of hepatocellular injury. But in NASH, you do have evidence of hepatocyte injury, like ballooning, with or without fibrosis. That's the difference. This is what differentiates fatty liver from NASH. So the incidence, basically, again, all my references will be at the end, so we can go through that later. A recent meta-analysis estimated that in Asia, it's about 52 per 1,000 person years. The West is estimated to be 28 per 1,000 person years. The same meta-analysis also estimated the global prevalence of around 25%. The highest being, and surprisingly, in the Middle East, with more than 31%, followed by South America, 30%, and the lowest prevalence was found in Africa at 13.5%. So the prevalence of NASH among NAFLD patients, this needed to be in patients who had liver biopsies. And those were basically classified into two groups. Patients who had the biopsy with a clinical indication, and that was estimated to be about 60%. And then patients who did not have a specific clinical indication. It was a random biopsy from living-related donors, etc. And that was estimated to be from about 7% to 30%, a very high range. So we conclude, based on all these estimates, that the prevalence of NASH worldwide ranges between 1.5 to 6.5%. So what are the outcomes of fatty liver disease? So one key factor is fibrosis. Fibrosis plays a very big role on these patients. So if you have fibrosis, you are at higher risk of having adverse outcomes and increased mortality. These patients usually have overall mortality rate increased compared to the general population. The most common cause of death in these patients is cardiovascular disease, independent of the diabetes, hypertension, all that disease associated with metabolic syndrome. Cancer-related mortality is one of the top causes of death in these patients. It is the third most common cause of HCC in the United States after alcohol and viral hepatitis. There were some small reports of HCC in patients with fatty liver without cirrhosis. This study was done in Veterans Affairs hospitals all over the US. So it's very important to know if the patient consumes alcohol or not, because sometimes you really can't tell the difference. By definition, what's a significant amount of alcohol intake? It's more than 21 standard drinks in men, more than 14 drinks in female per week over a 2-year period. And based on the National Institute of Alcohol Abuse and Alcoholism, a standard drink is about 14 grams of pure alcohol. That's considered significant. So we get these patients a lot in the clinic. You know, a patient gets referred to us for fatty liver seen on ultrasound done for other reasons, or a CT scan showing fatty liver. So how do we approach these patients? We have to look at two things. Does the patient have signs and symptoms of chronic liver disease, or liver disease as a matter of fact? The other thing is we got to look at the liver chemistries. Do they have abnormal LFTs, elevated liver enzymes? So if those things, one or both, are present, we should basically proceed and manage the patient with fatty liver disease and try to treat them. But if none of the above were present, then we have to look for, does the patient have metabolic syndromes? We have to treat the diabetes, the hypertension. We gotta get more history, see if there is any other causes causing the fat to accumulate in the liver, ask about alcohol, etc. So this is very important to know, to really classify a patient that has non-alcoholic fatty liver disease. One, the patient has to have steatosis, either by imaging or histology. Two, there has to be no significant alcohol consumption. Three, all the competing etiologies for hepatic steatosis needs to be excluded. Four, there are no coexisting causes of chronic liver disease, for example, like hepatitis C, genotype 3. So those patients usually require a lot of workup, and we have to exclude, like I showed you before, there are a lot of causes that can cause steatosis of the liver. You gotta rule out viral hepatitis. You gotta check ferritin. You gotta check autoimmune antibodies. Everything basically. So ferritin, for example, is one of the markers that you can see mildly elevated in patients with fatty liver disease. It does not necessarily mean that the patient does have iron overload. It can impact disease progression. And basically, if you have a serum ferritin that's more 1.5 upper limit of normal, that's associated with more advanced fibrosis in a study that was done on more than 600 patients. If you have the serum ferritin that's high and the saturation is high, or basically you've got a high iron saturation, you got to think about hemochromatosis, and those patients should go for a liver biopsy to rule out hematochromatosis. Autoantibodies. So most patients usually have low serum titers of autoantibodies in the form of ANAs and anti-smooth muscle antibodies. There was a study that was done on more than 800 patients with well-characterized FLD subjects from the NASH Clinical Research Network. And those patients were found to have significant high titers of autoantibodies, and it was present in 21% of these patients. So that's a high number. So when you get these high numbers, that doesn't mean that the patient does have autoimmune hepatitis, but it should raise a suspicion, and you should go for a liver biopsy as well. Okay. So in summary, basically, when we approach these patients, we have to really make sure that we exclude all other competing causes that can cause hepatic steatosis. We should complete the $1 million workup, getting all the antibodies, the iron, the copper, the ceruloplasmin, everything, okay? So if you do have serum antibodies and it's more than 5 times the upper limit of normal, and you've got high IgG levels, high total protein to albumin ratio, you should really think about autoimmune disease as well. Again, the initial evaluation, we should look for the comorbidities associated with diabetes, like diabetes, obesity, lipids, all these things. So some of the non-invasive tests that you can do prior to a liver biopsy is the NFS, which is the NAFLD fibrosis score. It's a non-invasive test. You take the age, the BMI, the fasting blood sugar, AST-ALT ratio, platelets, albumin. You put it in a calculation, which is on most medical calculators, and you get a score from F0 to F4. F4 is no fibrosis, F0 is no fibrosis, F4 is cirrhosis. Anything in between, it's anybody's call. So F0 is significant, F4 is cirrhosis, and that can give you a picture on how severe the patient's fibrosis is. Other tests, you've got the FibroScan, the MRE, that can give you, an idea of does the patient have severe fibrosis or not. So when to obtain a liver biopsy in patients with NAFLD? I can tell you from now, like most 99% of patients will eventually require a liver biopsy. But because it's the gold standard, it does have some limitations. It's expensive. It requires some experts to do the biopsy and expert pathologists to read the slides as well. Again, because you've got a lot of diseases that can cause steatosis. So the pathologist needs to differentiate with different stains, if there is copper, if there is iron, and so on. It does carry some morbidity. It can cause hematomas. After you do them, the patient needs to be admitted for a short stay for observation. And there are some reported cases of mortality, but that's very low. So when to get them? Basically, when to get a liver biopsy. If you do have increased risk of having steatohepatitis or advanced fibrosis, meaning if a patient does have metabolic syndrome, you go for a liver biopsy. If you have a high NFS, you go for a liver biopsy. If you have liver stiffness measured by the FibroScan or MRE, you go for a liver biopsy. And again, when you can't exclude the competing causes of steatosis, you go again for a liver biopsy. Like I said, it's, from the get-go, most patients will require a liver biopsy. So now we come to management and treatment. So who do we treat? Basically, two things we have to focus on. We treat the liver disease, and then we need to focus on the associated metabolic comorbidities. So patients without steatohepatitis or fibrosis do have excellent prognosis from liver standpoint. And usually medications are very limited to patients who have NASH, and it has to be biopsy proven, okay? So medications should not be given to patients with no NASH, and it has to be proven by biopsy. One of the things is lifestyle modifications, okay? Weight loss generally reduces steatosis of the liver. You go by a hypocaloric diet plus or minus exercise, okay? A combination of both is the best. Hypocaloric diet, you should basically decrease your daily requirements by 500 to 1,000 kcal per day. And if you put in 20 minutes, 3 times a week of exercise, you'll get the best results. So when patients tell you, okay, I walk every day, walking is not really an exercise. The patient needs to huff and puff and sweat to consider moderate intense exercise. Studies have shown that 3 to 5% reduction of total body weight showed that it improves steatosis, but a reduction of 7 to 10% of body weight is needed to improve most of the histology, fibrosis, ballooning, everything. So the goal is basically 7 to 10%. Exercise alone has been studied, and it showed that it can prevent or reduce steatohepatitis, but its ability to improve other aspects and the liver histology is unknown. Still studies are being conducted on that. So first form of medications we're going to talk about are insulin synthesizers, which are the metformins, thiazolidinodones, and the glucagon-like peptide 1 analogs. Metformin. Several studies have shown an improvement in serum AST and ALT and insulin resistance, but it does not improve liver histology. So with that said, it's not recommended to treat NASH patients. And this is based on 2 published meta-analyses. So those medications do have the rioglitazone and the pioglitazone. They do have broad effects on glucose and lipid metabolism. They have effect on vascular biology and inflammation. Studies have shown that they improve hepatic steatosis, okay, with rosiglitazone, but it did not improve inflammation or fibrosis. Rosiglitazone in most countries is not available due to some controversial finding of increased coronary events. On the other hand, pioglitazone, 45 milligrams a day, improves liver histology in patients with and without type 2 diabetes. Again, we should use them on biopsy-proven NASH. Risks and benefits should be discussed with each patient before starting this medication. Weight gain is the most common side effect of this medication, and it ranges from 2.5 to 5 kilograms in a 1 to 3 year period. Bone loss is another common side effect, and it occurs mostly in women. Glucagon-like peptide analogs. In a recently published randomized placebo-controlled trial, basically consisted of 52 patients with biopsy-proven NASH. It was administered once daily, sub-Q, for 48 weeks, and it was associated with the resolution of steatohepatitis and less progression of fibrosis. Although the results looked nice, it was associated with greater weight loss, and it had lots of GI side effects, nausea, vomiting, diarrhea, things like that. So for now, it's really premature to consider it as a treatment for NASH. Vitamin E. We all know that oxidative stress is considered to be bad, and it's one of the key mechanisms for hepatocellular injury. Vitamin E is an antioxidant and has been investigated to treat NASH. And it showed that it decreases the AST and ALT level, and it showed that there is improvement in steatosis, inflammation, ballooning, and resolution of the steatohepatitis in a proportion of non-diabetic patients with NASH. It does not have any effect on fibrosis, though. So one meta-analysis suggested that doses of more than 800 international units a day was associated with an increased all-cause mortality. Several studies, basically the study was criticized because the study did not include low mortality patients. Patients with other drug administrations were not considered. Smoking was not considered in the study. Then a large meta-analysis was done and included 57 studies with more than 250,000 patients followed from 1 to 10 years, showed that relationship is not there. So again, it's debatable for now. There is another side effect that basically was mentioned is prostate cancer. A large retrospective controlled trial published in 2011 showed that 400 milligram international units was associated with increased prostate cancer. So again, for now, daily dosing of 800 international units a day improves histology in non-diabetic adult patients with NASH. Until we have more data on vitamin E, we should not use it on diabetic patients. We should not use it on patients without a liver biopsy, and we should not use it on cirrhotics. Again, risks and benefits needs to be discussed with every patient. Bariatric surgery has a role in obesity, but really we can't say that it can be a treatment for NASH. It's good to improve metabolic syndrome, but again, not NASH, and it's too early to say. In terms of patients who have compensated cirrhosis, it will depend on a case-by-case basis and should be done by an expert bariatric surgeon. Orzo and omega-3 fatty acids studies have shown that they have no role in treating NASH or fatty liver disease. Two agents are being tried right now, obeticholic acid and elafibranor. Those are being tested right now. A little bit on obeticholic acid. So it's a potent farnesoid X receptor agonist. The way it's being tried, 25 milligrams per day, showed that it improves steatohepatitis and fibrosis over a 70-week period in a large multi-center phase 2B clinical trial. It's associated with dyslipidemia and itching. It was recently approved to treat PBC, but till now we can't use it until we have more data, and we recommend not to use it off-labelly.